Hi, it's Jeff Mulligan. Welcome to another SRS podcast. This is a special one as part of our sponsor series where Globus Medical will be presenting today.
Hello, and welcome to Tackling Complex Deformity Procedures with Excelsius GPS. I'm Brittany Mead, the Senior Clinical Manager for Imaging, Navigation, and Robotics at Globus Medical, and I'm going to be your host for today. I couldn't be more excited to introduce our speaker, Dr. Themi Protopsaltis.
Thank you so much for having me.
Would you mind giving our guests a short introduction on yourself and your practice?
Sure. My name's Themi Protopsaltis. I'm Chief of Spine Surgery at the NYU Langone Health System. My practice is comprised of both cervical and thoracolumbar deformity, as well as bread and butter degenerative surgery on the spine. And I've been using Excelsius GPS going on 3 years now for both my deformity cases and my degenerative cases.
What challenges did you encounter really with your cases that drew you into robotic-assisted surgery?
I remember being very excited to use the technology, and it was interesting because there was definitely a buzz among the techs, the nurses, the residents, the fellows. Everyone wanted to be a part of that first case, and it was the first case in New York State. I remember, I was nervous and everything, but at the end of the day, it's just a matter of trying to solve a problem and like a puzzle, and try to figure out how to make it run as smoothly as possible. So one piece of advice I would give to people as they embark on their first case or first few cases is to take a step back every now and then and take a think about what the workflow feels like and whether or not a different workflow might improve how the case moves along. And so one of the things we realized a few cases into our experience with the robot was that we may want to change when we're doing certain things. Like traditionally I was doing interbody fusions first and putting cages in and then doing screws after that. And with the robot, you want to, especially if you're using a preoperative CT workflow with intraoperative fluoroscopy, that type of registration works much better when the minute you do your registration, you go right into placing your screws. I adopted single position lateral surgery a lot more frequently when I had the robot because placing screws in the lateral position was much less stressful. So with the robot, you always want to do the most critical part of the case where the fidelity needs to be as high as possible right at the very beginning. So that's my advice to people starting out.
You brought up a really great point about kind of taking a step back and thinking about the workflow when you're first starting out. From a training perspective, we've kind of bypassed this area where the newer Excelsius users are doing degenerative cases, and it's more deformity. And, we've always taught you really want to start out small and then work your way up to the bigger cases, kind of slow down to speed up. What recommendations would you have for surgeons coming in and saying, I really want my first case to be a big T10 to pelvis?
It's not a bad idea to try to work the robot into lots of different cases. I like the idea of trying to bring it in, but what the surgeon should recognize is that you don't have to use it for the entire case, especially in the beginning. As you use the robot, if you encounter some issue, give it, say, 15, 20 minutes to troubleshoot. And then if you think it's going to take much more time, always have a plan B in place, ready to move on. And one of the great things about Excelsius is that you can start out with a plan of doing preoperative CT, intraoperative fluoroscopy. And if that registration for some reason doesn't work out or something gets bumped, or say you no longer are confident in the registration and you think that there'll be an inaccuracy in malpositioned screw, you need to be able to either abandon that case with the robot or think about bringing the robot back in and maybe either doing another spin if you have an intraoperative fluoro in place, or take another couple shots and register again with the preoperative CT, or even convert to the two-dimensional workflow. And that was one of the things when we first started out. We had a bunch of patients that would come in with CTs already, and we didn't have the workflow in place in the office to get the 1 millimeter cut CTs so that it would be maximum fidelity with merging with the registration during the case. And a lot of times we were trying to push the envelope a little bit, or if it wasn't fine cut, or if it was 2 millimeter slices or 3 millimeter slices, it may not work so well. I started having a backup plan of moving to two-dimensional fluoroscopy workflow, and that worked very well as well, especially if the pedicles are decent size. You don't really have a lot to worry about, and you can get those screws in very efficiently with just a few fluoroscopy shots. Always having a plan B and a plan C is helpful when you're doing robotics. I think that's one of the things that people need to recognize. And for a big case, if you're tackling that during your learning curve, maybe do parts of the big case and not the whole thing. Like do some of the more challenging screws, get the UIV screws out of the way, and then move to a pedicle that's really small like L1 or L2, maybe a pedicle that frequently has problems like L5, and then do S2 iliacs to finish off and freehand everything else. And you'll find that just putting in those 6 difficult screws and the S2 iliacs, it makes for a very pleasant rest of the case. In terms of using the robot in new ways, I think I didn't shy away from using the robot in the lateral position. You just have to get used to 2 things at once. If you're not used to doing cases in the lateral position and putting screws in that position, doing a single position lateral case is a great way to start using the robot in a new way. And so getting the feel for what that's like and having the robot there as an assistive device to put those screws in. And we did a study at our institution. You save up to almost 2 hours on average if you don't flip the patient. And you say, oh, that's not going to happen at my institution. We run a tight ship. We've got great help to reposition the patients. But it's not just repositioning the patient. No matter how good your moving team is, there's also closing the wound sequentially. There's draping sequentially instead of draping one time, closing the wound simultaneously, and doing some of the work at the same time. So it does actually amount to close to 2 hours on average.
With your experience in the hundreds of cases that you've done, you've really pushed the system and helped us, at Globus learn a lot about Excelsius and what we're capable of doing. With all of the experience that you have with Excelsius GPS and the hundreds of cases that you've done, what has really been, one of your most memorable robotic assisted cases so far?
I always remember that first case, and then there's another one that comes to mind. The first case was great. It was a patient. I didn't have a preoperative CT on the patient. I just had an MRI. She had a 2-level lumbar degenerative spondylolisthesis, so 2-level slip, spinal stenosis. I was setting her up to do a minimally invasive TLIF, and I grabbed the robot and said, let's do this as the first case. And there's no pre-op CT, no problem. We brought the fluoro in, shot true APs and laterals at each level, and did fluoroscopic workflow, placed the screws. The screws went in exactly as I planned them on the robot computer. That's what the postoperative x-ray looked like. Perfectly symmetrical AP and lateral screws. And it's just like putting in percutaneous screws. You start at the 3 o'clock and 9 o'clock position. You advance into the pedicle till you breach the back of the vertebral body, confirm that you're not too medial, and then you advance all the way into the body. So we went through that just like placing fluoroscopic pedicle screws, and then did the inner body, and again used the pointer to check where I was in the disc space, how deep, how contralateral, where the cage was going to go, and was it going to be right in the midline for the bullet cage. And I did a 2-level MIS TLIF and didn't put lead on, and it was the most pleasant and eye-opening experience because it blew my mind that I could now start doing minimally invasive TLIFs without the weight of my lead on my back and getting perfect x-rays because the robot's matching the idea I have in my head for where those screws need to go. Whereas previous to that, you've got Jamshidi needles, you've got a fellow assistant on the other side. They're trying to put the pedicle screw in kind of similar to you, but invariably nothing ends up exactly similar. And the other case was one of a severe lumbar coronal deformity with an apex around L2-3, foraminal stenosis in the fractional curve causing radiculopathy, big trunk shift in the patient, and really no deformity above L2. And I thought that would be a great case to do a single position, anterior, lateral, and posterior 3-part surgery in one stage. And I used the robot to place the screws right off the bat from L2 down to S2. And then I had the navigation available. This was predating navigated inner bodies, but I had the navigation available to probe the anatomy and understand where the lateral start points might be and that kind of thing. So I found it to be hugely beneficial, not taking 100 fluoro shots to get the case done because the posterior part of the case was percutaneous, including the S2 iliacs. And I realized that there was tremendous potential here for this technology to really make something like that, a minimally invasive 3-part surgery, run very smoothly with very little stress. When you have rotational deformities and you're in a new position that you're not used to operating in, like the lateral position, that can add a lot of stress to your case. But coming to work every morning, knowing I can tackle a minimally invasive lateral screw case, and really just watch my trainees do the majority of that case, because I can see what's happening on the screen. I know where those screws are going at all moments, and I can see whether they're forcing the end effector or the instrument in such a way that's causing warning alarms to go off on the robot. So I know when those screws are going in perfectly and when they're not. I don't need to have my hand right on the instrument to understand that. And that's where the stress relief comes from.
What has really been your experience with residents and fellows and the training environment that they have with robotic surgery now?
So I think robotics is here to stay, and it's the way of the future. And I think if you train at a place without a robot, then that's a deficit in your future understanding of spine surgery that you're going to need to fill. You might as well get it as you're training. And I think we tried as an institution and as a program to offer not only robotics, but also various forms of navigation. And we've been able to give those tools to the fellows that come through and the residents that come through so that they understand where things are going, the trajectory of technology. And it's just as important, because the way that we do surgery now is not the way that I did it when I trained as a resident. It's not the way that I did it when I was a fellow. There's always advances, and that goes true for the people that taught me and the people that taught them, obviously. So you have to be on top of technology, and you have to be able to embrace changes in the way that you do things, because you can't just be a dinosaur. You have to evolve with the times. And when something is clearly a benefit and everyone gravitates towards it, you have to be on top of the wave as well. You don't have to be the earliest adopter, but being a little bit ahead of the curve doesn't hurt. And what I tell fellows, once they get used to doing the robot and using it and they understand what the benefit is, then they start worrying, well, wait a second, when I get out and practice, I may not have a robot, or they take a job where there isn't currently a robot and they start getting nervous and they want to start doing screws percutaneously with fluoroscopy, and they want to start putting in more freehand screws. And so I accommodate them and I explain to them, listen, this is one of the greatest intraoperative, real-time, 3-dimensional anatomy tools that you have at your disposal. So you can in an open deformity where we're using the robot and the navigation from Globus, I'll tell them, okay, look, we're going to put the UIV screws in with the robot because those are really important, and I don't always expose the landmarks as much in order to maintain some of the muscle attachments and the neurovascular attachments to the facet joints that might preclude proximal junctional failures from occurring. So we place those screws in basically percutaneously at the top. And we prepare the joints right below that for fusion. And then every other screw below that is fair game for the fellows to take a stab at doing freehand. So they'll do freehand screws if that's what they want to get under their belt. And then we'll check the anatomy of their screw track. We'll look at how we planned the screw with the robot to begin with. We look at where that screw ended up, whether the screw track ended up, based on what the fellow's conception of the anatomy was and the preoperative CT. So we're not using it as a crutch. We're not using it as a flight simulator where we're navigating the instruments and going down the pedicle and that kind of thing. We're doing the hole, we're making the screw track, and then we're checking it with the anatomy, and we can see the preoperative plan as well, since we have the benefit of the robotics and preoperative planning from the robot. So it's an interactive tool, and I try to give them that understanding, and then they don't shy away from the cases that have robots in them. And you'll see this phenomenon at training courses where the robotics table is a little bit empty and everyone's trying to freehand screws, and they're over at the table with the filleted open anatomy. And that's fine for a training course, but in real time with real patients, I think it's if you have that tool available, you got to use it. And the fellows and the residents can still get a lot of learning out of it.
It's funny you said that. We just recently had a fellows day at headquarters, and the robotic stations outweighed the traditional station. I thought that was really exciting to kind of see where Excelsius is transitioning. And, I think in the past, historically, that has definitely been the case. We didn't really get as much traffic at the robotics, but I'm starting to see that change a little bit, which is exciting. When you were getting into robotics, with there being so many other technologies available, what made you choose Excelsius?
So as an institution, and in particular our division in orthopedics and spine at NYU, we never really embraced navigation traditionally because it just seemed like the technology was slow. We didn't find that there was a huge benefit over what we could potentially do freehand and efficiently with the way that we had developed our protocols for doing cases with two surgeons, and especially the big complex deformities. There are ways of getting the screws in accurately without necessarily even bringing in fluoroscopy. So we were very confident in our freehand technique and our approach to deformity cases with two surgeon type of surgery. And at the end of the day, navigation meant a big O-arm, 3-dimensional imaging unit, something that, you had to have the camera, the line of sight, the space to accommodate it. And our ORs weren't necessarily the largest. But when Excelsius came out and there was a clear integration between robotics and navigation, we saw this as a big opportunity. And we recognized that robotics was another level of navigation, that now that it wasn't just that you're at the moment navigating into a pedicle. There's all this pre-planning that can go into robotics where you can analyze a case and break it down and say, oh, I see there's rotational deformity. If I'm going to drop this rod, I'm going to cheat the L3 screw a little bit more lateral to medial, the L2 screw a little bit more medial to lateral. That'll line up the screw heads a lot better.
That's awesome to hear. When you are looking at your complex cases that you're doing, these longer constructs, we often get asked a couple of different questions about setup. Where is the DRB or the dynamic reference base? Where do we put the spinous process clamp? I'm sure that you've trialed and errored a bunch of different ways of completing that case, but what types of tips and tricks can you share to have a successful deformity case with Excelsius?
So with deformity cases that I'm doing in the lateral position where I'm doing A-lifts, laterals, I'm putting in pedicle screws percutaneously, let's say it's T12 to S2 or L1 to S2 or L2 to S2. I'm putting the dynamic reference base, the quattro spike that the dynamic reference base goes on. I put that from lateral to medial and from caudal to cephalad on the upper, the higher posterior superior iliac spine. That's my go-to place for a lumbar case. And that includes those lateral deformities. And I always start from cephalad to caudal with the screws. If I'm in the lateral position, I do the downside first so I don't push the patient over too much with the instruments and lose some amount of fidelity with the registration. So downside screws 2 to S1, then upside screws 2 to S1, and then I do the downside S2 alar iliac. And then if I'm navigating inner bodies at the top, I'll go to the inner bodies before I do the S2 alar iliac where the dynamic reference base is, because just in case it bumps it, I don't want to be able, I don't want to have to lose anything, and I might be able to freehand nav at least the start point and potentially the whole screw at the end of doing the inner bodies anyway. So I'll do the cephalad to caudal progression also for the inner bodies. So if I was doing a 2 to the sacrum, do 2, 3, then check the anatomy, make sure that L3 pedicle screw and L4 pedicle screw are still pretty good in terms of fidelity in the anatomy check. Then I'll do the L3-4 inner body. And then I might delay my approach guy from doing the approach. And right as I'm starting to do the inner bodies, I let the approach surgeon, the vascular surgeon, get going on the 4-5-5-1 exposure. And he gets down to the spine. I'm finishing up the inner body and he's ready for me. I go right to doing the ALIF. So that's the whole point about simultaneous work when you're doing single position surgery like that. You can have the ALIF approach surgeon getting the approach while you're doing some other part of the case. In terms of a prone deformity, really a lot of different options work pretty well. Like in T10 of the pelvis, I'll still fixate on the PSIS, and you can do it whatever really. Lots of different thing works. So if you want the dynamic reference base on the right PSIS, oftentimes I'll just go straight in or from medial to lateral, caudal to cephalad. But if I'm working where I want the DRB on the left side, I'll just frequently just put it the same way I do in the lateral position, where it's going lateral to medial, caudal to cephalad.
We always get the most questions during cases or case preparation about, where do I put the DRB for this case? So I think that is extremely helpful because we've definitely seen placement go wrong and the challenges that we face with that. So I really appreciate your feedback on that. I think it's going to be extremely helpful. When we look at those larger constructs, a lot of people are incorporating iliac bolts or S2AI screws. How has Excelsius really benefited you when tackling those screw placements?
I learn something every case now, particularly because of that interactive three-dimensional anatomy that I spoke about when I encourage the fellows to really think about what the robot's showing them during the case. And I'll do cervical cases, and I'll think about, where the pedicles are, if I needed to do a pedicle screw. Just the other day, I had a woman that had a severe cervical thoracic deformity that was almost chin on chest, because she had failed so catastrophically above a T4 to the pelvis fusion, and she developed horrific 90-degree deformity, more than 90-degree deformity, and her chin was very close to her chest. She couldn't live this way. She told me that several times, and we undertook her surgery. I did navigate screw fixation in C2, both laminar and par screws. She didn't have very big pedicles, and unfortunately, because of a variety of reasons, she ended up pulling her instrumentation out, and I've never seen that triple fixation in C2 pull out before, but it did in this woman. And I had to revise her, and having the option of putting in subaxial pedicle screws was huge. So it can take you places that you didn't expect to go, and with a lot more confidence that you would otherwise have. And I'm not saying these cases are for everyone, and certainly I wouldn't have attempted that case without a significant amount of planning going into it. But having that tool available to me was a huge advantage going into that case. Even in regular cases, you'll see deformities where there's coronal deformity. Some of the pedicles are dysplastic. Some of the vertebrae are asymmetrical. Those start points aren't usually exactly where you think they are, and the trajectories aren't exactly where you think they are. And you see that in real time with the three-dimensional anatomy in front of you. And you learn something from every single case like that. You can see where the start point varied relative to where you usually put it. And you may go back to that CT and see exactly why that was the case. And that's what I try to impress on the fellows. So you just realize that the start point here is a little different than what you expected it to be. Why was that? Go back and take a look at that T12 pedicle and the concavity of the curve and figure out why that start point was there, So that's something I'm learning from the robot every day.
That's great. So besides your learning, the lack of lead, what advantages does Excelsius really provide to you beyond the OR?
In general, I have patients that seek me out because I do robotic spine surgery. I'll have patients come and they might have read something, an article that was written, and I've had several patients come to me, and they'll quote that news flash that came across their desktop, and they'll say, "Doc, do you think I qualify for that kind of surgery?" And in some cases they do, in some cases they don't. But it's clear that people are getting more savvy and understanding of what technology is out there for their different conditions, and they're asking all the questions that you'd expect them to once they gain that knowledge. And I think it's important to speak that language and be able to interact with the patients that are more savvy, and then to point out to patients that aren't expecting it necessarily that you do have this advantage at your disposal of placing screws in very efficiently with a robot, and that gives the people that didn't come in expecting it good peace of mind. The surgeon cares. He's got this great technology that he's going to use for me. And patients notice, doctors referring you notice. This is paving the way for future utilization of the robot in ways that we don't expect right now, that could make their way to patients' desktops and word of mouth. And then they'll realize that, maybe in the future, they need a robot to help with the decompression or something like that.
My dad had just gone through a T11 to pelvis, and one of the first things he asked me was, can this be done with Excelsius? So I think it's really, couldn't be more exciting right now to see really where we're going. But I do have one last question for you, and it's a question I get asked constantly in training scenarios, out at first cases, and the question always is, will the system slow me down? So I was wondering if you could talk a little bit about your thoughts on that.
Once the registration is complete, the system's faster than putting in a pedicle screw, especially if you're doing it fluoroscopically. If you're doing percutaneous pedicle screws with fluoroscopy assistance, the robot is a lot more efficient because you start firing the screws in one at a time. It's still faster than even trying to simultaneously, you and a assistant putting in pedicle screws at each level. But it's the whole registration part that's where you need to make your workflow as efficient as possible. Once you get used to it, you can take just a few shots. You can usually get 2 or 3 levels in every lateral. The preoperative CT workflow is our workhorse. We use it all the time, much more frequently than intraoperative CT. And part of that is the clarity of the preoperative CT is so high. And once we get that merge, and it's segmental registration, so the robot's looking at each level individually. So even if there's been some inner body work done right preceding placing the pedicle screws, it's still a lot better in terms of getting the registration than it used to be, partly because the engineers are so on top of improving the software and the robot system that they've made it so efficient that even in a grade 2 spondy, we'll frequently do inner body first and then flip the patient and do the posterior screws if that case wasn't amenable to a single position lateral workflow. I think there's a lot of great time savings that can be won when you start doing simultaneous parts of the surgery. So I encourage people, as they're getting used to using the robot, to tackle a single position lateral case, to tackle a lateral ALIF case. If you have a 2-level DGen Spondy 4551, think about doing a lateral ALIF and getting used to that workflow and placing those screws at the very beginning in the back. And then as you're finishing up your screw workflow, you let the approach surgeon get going on doing the approach. And then pretty soon he'll have you down, and then you fire in your inner bodies. It's a great way to save time in your workflow. Basically, the learning curve with the robot is the time that you end up using to get used to the system. And the more we've used the robot, the more we've helped Globus understand the robot better, help the field technicians understand the robot better, and help the engineers understand the robot better. And so our learning curve is going to bleed away everyone else's learning curve. And that's the beauty of a system that's getting very popular and deservedly so, because it has excellent results and it's a very friendly user interface.
We have always learned something new than when we come into your cases. I know I have learned a ton. Like you said, I think, the cases that you and NYU are doing is incredible, and we learn something every single day. So, I really can't thank you enough for being so amazing in the OR and being patient and trying all these new procedures and techniques with Excelsius, but also for your time today and sharing all of your expertise with all of our listeners. I really appreciate you spending that time with us today.
Thank you, Brittany. It's been my pleasure.
Wonderful. Well, that is all we have for today. Thank you all for listening, and have a fabulous day.